What are the key risk factors for gestational diabetes, and how do these risk factors contribute to the development of the condition? Answer: gestational diabetes (GDM) is influenced by a combination of genetic, environmental, and metabolic risk factors. Key risk factors include obesity. Excess body fat increases insulin resistance, which can impair glucose tolerance and increase the risk of GDM. Family history of diabetes. A first-degree relative with type 2 diabetes increases the risk, highlighting a genetic predisposition. Advanced maternal age. Women over the age of 25, especially those over 35, have a higher incidence of developing GDM. Ethnicity. African American, Hispanic, Native American, and Asian American women are at higher risk due to genetic and socioeconomic factors. History of gestational diabetes. Women who had GDM during a previous pregnancy are at higher risk of recurrence in subsequent pregnancies. Polycystic ovarian syndrome, PCOS is linked to insulin resistance, increasing the likelihood of GDM. A 32-year-old pregnant woman, Mrs. Lee, has recently been diagnosed with gestational diabetes. She is concerned about the impact of the condition on her baby and seeks guidance on managing the condition. What are the recommended first-line management strategies, and how should they be individualized? Answer: in managing gestational diabetes, a personalized, multidisciplinary approach is essential. The first-line strategies for Mrs. Lee would include nutrition therapy. Mrs. Lee should receive counseling from a registered dietitian to create a balanced meal plan. The plan should focus on consistent carbohydrate intake with an emphasis on complex carbohydrates and portion control to prevent postprandial hypoglycemia. Physical activity. Regular moderate exercise, such as walking, is recommended to improve insulin sensitivity and glucose utilization. Mrs. Lee should aim for at least 150 minutes per week of moderate intensity physical activity. Blood glucose monitoring. Self-monitoring of blood glucose (SAG) should be encouraged, with targets of 95 mdl or lower before meals and 120 mdl or lower 1 hour after meals. Insulin therapy. If lifestyle modifications fail to maintain optimal blood glucose levels, insulin therapy may be initiated. Insulin is the preferred medication as it does not cross the placenta and is safe for both mother and fetus. Explain the pathophysiology behind the development of insulin resistance in pregnant women with gestational diabetes, and how does this resistance impact maternal and fetal health? Answer: during pregnancy, hormonal changes lead to increased insulin resistance, a key feature of gestational diabetes. The placental hormones, including human placental lactoger (HPL), cortisol, and progesterone, play significant roles in increasing insulin resistance. These hormones reduce the body's sensitivity to insulin, requiring the pancreas to secrete more insulin to compensate. In women with gestational diabetes, the pancreas cannot produce enough insulin to overcome this resistance, leading to hypoglycemia. Impact on maternal health. Hypoglycemia. Elevated blood glucose can lead to symptoms like excessive thirst, frequent urination, and fatigue. Increased risk of preeclampsia. The stress of uncontrolled hypoglycemia can increase the likelihood of high blood pressure and protein in the urine, leading to preeclampsia. Increased risk of cesarean delivery. Maternal obesity, large fetal size, and labor complications can lead to higher rates of cesarean section. Impact on fetal health. Macrosomia. Elevated glucose levels can lead to excessive fetal growth, increasing the risk of birth injuries and requiring delivery by cesarean section. Neonatal hypoglycemia. After birth, the baby may experience low blood sugar as it adjusts to the sudden drop in maternal glucose supply. Respiratory distress syndrome. Babies born to mothers with uncontrolled gestational diabetes may have immature lungs and are at higher risk of respiratory complications. Mr. Johnson, a 15-year-old with type 1 diabetes, is struggling with adherence to his insulin regimen and blood glucose monitoring. His AC is consistently above target. His parents are concerned and have asked for advice on how to improve his management. What strategies should the diabetes educator recommend to Mr. Johnson and his family? Answer: to improve Mr. Johnson's adherence and blood glucose control, a comprehensive approach is needed involving both medical strategies and psychosocial support, education and motivation. Mr. Johnson needs a thorough review of the importance of tight blood glucose control in preventing long-term complications. The educator can help him understand the connection between lifestyle choices, blood glucose levels, and health outcomes. Individualized insulin regimen. Since he is a growing adolescent, adjustments to his insulin regimen may be necessary. A combination of basal and bolus insulin with flexible adjustments based on meals and activity may be more effective in addressing insulin resistance during puberty. Technological aids. Introducing insulin pumps or continuous glucose monitoring (CGM) systems can simplify management and help Mr. Johnson better understand the effects of food, exercise, and stress on his blood glucose levels. Psychosocial support. Adolescents often experience difficulties with diabetes management due to social and emotional challenges. Mr. Johnson may benefit from counseling to address any feelings of diabetes, burnout, or non-compliance. Parental involvement. Mr. Johnson's parents should be actively involved in his care. Regular family meetings with the healthcare team to discuss progress, challenges, and ways to better support him in his self-management can improve outcomes. By addressing both the medical and psychological aspects of diabetes management, Mr. Johnson is more likely to achieve better adherence and improved glycemic control. How do the growth and development considerations in children with diabetes impact insulin dosing and management strategies, and what special considerations should be made for prepubertal and pubertal children? Answer. Growth and development significantly affect insulin requirements in children, particularly during periods of rapid growth such as prepuberty and puberty. Prepubertal children. These children have relatively stable insulin needs, with basal insulin requirements increasing gradually as they grow. Insulin to carbohydrate ratios may be relatively consistent during this stage. Regular adjustments should be made to match growth, but insulin resistance is not yet significant. Pubertal children. Puberty induces insulin resistance due to hormonal changes, particularly increased secretion of growth hormone and sex hormones. This leads to higher insulin requirements. Special considerations include insulin resistance. Pubertal children may experience significant fluctuations in insulin sensitivity, requiring frequent adjustments in both basal and bolus insulin doses. Impact of growth hormones. Growth hormone surges during puberty can lead to higher blood glucose levels, necessitating higher insulin doses. Monitoring of growth patterns. Regular assessment of growth, height, weight, and blood glucose trends is essential to detect any issues early and adjust therapy accordingly. What are the key differences in the management of type 1 diabetes in children versus adults, and what considerations must be made regarding insulin therapy in pediatric populations? Answer. The management of type 1 diabetes in children differs from adults in several key areas. Insulin dosing. Children typically have higher insulin sensitivity than adults, requiring smaller doses for the same blood glucose response. Insulin dosing must be adjusted for age, growth, activity, and meal intake. Growth and development. As children grow, their insulin needs will change. Regular assessments are needed to adjust doses to account for changes in body weight and growth rates. Psychosocial factors. Children and adolescents may struggle with adherence to treatment due to peer pressure, school activities, and emotional factors. Support from family and school staff is critical in these situations. Type of insulin. Insulin regimens in children may involve more frequent adjustments in basal and bolus insulin to account for their lifestyle and growth. Continuous glucose monitoring (CGM) and insulin pumps are often helpful in improving diabetes management. AC targets in children are typically less stringent than in adults to avoid the risk of hypoglycemia, especially in young children who are not yet able to detect low blood sugars effectively. A target AC of less than 7.5% is often recommended for children under 19 years old. What are the current guidelines for screening for type 2 diabetes in children, and how should a diabetes educator approach screening for at-risk populations? Answer. The American Diabetes Association, ADA, and other health organizations recommend the following guidelines for screening children for type 2 diabetes. Start screening at age 10 for children who are overweight or obese and have one or more additional risk factors such as family history of type 2 diabetes, ethnic background, e.g. Hispanic, African American, Native American, Asian American, signs of insulin resistance, e.g. acanthosis nigricans, hypertension, dyslipidemia, maternal history of gestational diabetes, screening frequency. Annual screening is recommended for children who are at risk using fasting plasma glucose (FPG) etch-back. If a child has two abnormal test results, a diagnosis of type 2 diabetes may be confirmed. Explain the importance of carbohydrate counting in the management of pediatric diabetes, and how should A diabetes educator teach a child to accurately count carbohydrates for insulin dosing. Answer: carbohydrate counting is critical for managing blood glucose levels in children with diabetes because carbohydrates have the greatest impact on postprandial blood glucose levels. To effectively teach a child carbohydrate counting, education. Children should be educated on how different types of foods, e.g., fruit, bread, pasta, affect their blood glucose, portion size. They need to understand the concept of serving sizes and how to measure or estimate the carbohydrate content in their food. Label reading. Teaching children to read food labels for carbohydrate content is essential. Educators should provide practical exercises to help children become confident in identifying carbohydrates in common foods. Insulin to carbohydrate ratio. Once carbohydrate counting is understood, the educator should work with the child and their family to develop an insulin to carbohydrate ratio, adjusting insulin doses based on the carbohydrate content of each meal or snack. What are the long-term risks for developing type 2 diabetes after gestational diabetes, and how can diabetes educators help women manage their risk post-pregnancy? Answer: women who have experienced gestational diabetes are at an increased risk of developing type 2 diabetes later in life. The risks include insulin resistance. Gestational diabetes is often a sign of underlying insulin resistance, which may persist postpartum, increasing the likelihood of developing type 2 diabetes. Obesity. Excess weight gain during pregnancy can also increase the risk of type 2 diabetes after delivery. Postpartum management strategies include lifestyle modifications. Women should be encouraged to adopt healthy eating habits and engage in regular physical activity. Postpartum glucose screening. It is recommended that women be screened for type 2 diabetes 2 weeks after delivery, and then every 3 years thereafter. Weight management. Maintaining a healthy weight is crucial to reducing the risk of progression to type 2 diabetes. What are the clinical signs and symptoms of hypoglycemia in children with diabetes, and how should a diabetes educator teach parents to recognize and treat hypoglycemia at home? Answer: hypoglycemia in children with diabetes can present with a variety of symptoms including mild hypoglycemia, sweating, shakiness, irritability, hunger, and pallor; moderate hypoglycemia, dizziness, confusion, difficulty concentrating, and fatigue; severe hypoglycemia, seizures, unconsciousness, or inability to respond. Parents should be taught to test blood glucose levels immediately when symptoms of hypoglycemia are observed. Treat with fast-acting carbohydrates. Give the child 1.52 grams of glucose, e.g., 4 oz of juice or regular soda, glucose tablets. If blood glucose is below 7 mdl, retest after 15 minutes to ensure blood glucose has returned to a safe level. If symptoms persist, repeat the treatment. Emergency care. If the child is unconscious or unable to consume food or drink, glucagon injections should be administered and emergency medical services should be contacted immediately. What is the role of glycemic control in preventing the development of diabetic retinopathy, and how does its progression impact a patient's quality of life? Answer: glycemic control plays a significant role in preventing or slowing the progression of diabetic retinopathy, a common complication of diabetes. The relationship between hypoglycemia and the development of retinopathy is well documented in clinical studies. Poor glycemic control increases the risk of microvascular damage, leading to the breakdown of the blood-retina barrier. Chronic hypoglycemia causes endothelial dysfunction and increased oxidative stress, which accelerates the damage to retinal capillaries. The progression of diabetic retinopathy can significantly impact a patient's quality of life, affecting vision and leading to blindness if untreated. Effective management of blood glucose alongside regular eye screenings is key to preventing vision loss. The American Diabetes Association (ADA) recommends that patients with type 1 diabetes undergo annual dilated eye exams starting 5 years after diagnosis, and those with type 2 diabetes should begin exams shortly after diagnosis. Relevant guidelines and laws. ADA guidelines for annual diabetic eye exams for patients with diabetes. The Early Treatment Diabetic Retinopathy Study (EDA's) findings on glycemic control and retinopathy. How do psychosocial factors such as diabetes distress and depression influence a patient's ability to effectively manage their diabetes? Answer: Psychosocial factors such as diabetes, distress, and depression can significantly hinder a patient's ability to manage their diabetes effectively. Diabetes distress refers to the emotional burdens that individuals with diabetes may experience, including worry about complications, daily self-management tasks, and treatment adherence. Depression is also common among people with diabetes, with studies showing a higher prevalence compared to the general population. Both conditions can impair self-care behaviors, reduce adherence to medication regimens, and negatively affect glycemic control. Individuals who experience diabetes distress may be more likely to feel overwhelmed by the demands of the disease, leading to poor decision-making and neglect of necessary self-management practices. Depression can lead to a lack of motivation to engage in healthy behaviors, such as regular physical activity or healthy eating, which are crucial for managing diabetes. Relevant guidelines and laws. ADA guidelines on psychosocial care and mental health screening in diabetes management. The National Institute for Health and Care Excellence NICE guidelines on managing depression in people with diabetes. Mr. Harris, a 55-year-old male with type 2 diabetes, presents to his healthcare provider complaining of increased thirst, frequent urination, and fatigue. His blood glucose is significantly elevated at 300 ADL. What is the most likely diagnosis, and what are the key steps in managing his condition? Answer. Mr. Harris is likely presenting with hyperosmolar hypoglycemic state, a severe acute complication of diabetes commonly seen in patients with type 2 diabetes. HHS is characterized by extremely high blood glucose levels, often greater than 600 mdDL, dehydration, and an absence of significant ketone production. Symptoms such as extreme thirst, frequent urination, and fatigue are common. The key steps in managing HHS include immediate rehydration with intravenous fluids to correct dehydration, which is a major feature of HHS. Insulin therapy to lower blood glucose levels gradually. Electrolyte replacement, particularly potassium, as shifts in electrolytes can occur during treatment. Close monitoring of blood glucose electrolytes and renal function to guide therapy. Unlike diabetic ketoacidosis (DK), which involves ketosis, HHS does not typically produce significant ketone bodies. Therefore, distinguishing between these two conditions is essential for appropriate management. What is the significance of regular screening for diabetic nephropathy, and how does early detection impact long-term outcomes in patients with diabetes? Answer. Regular screening for diabetic nephropathy is crucial for preventing the progression of kidney disease in patients with diabetes. Early detection allows for timely intervention, which can delay or prevent the onset of end-stage renal disease (ED). The most common methods for screening diabetic nephropathy include urinary albumin to creatinine ratio (UACR). Elevated UACR is the earliest sign of kidney damage in diabetes and is recommended as part of the annual screening. Serum creatinine and estimated glomerular filtration rate (EGFR). These tests help to assess kidney function and detect any decline. Managing blood glucose and blood pressure effectively is crucial for reducing the risk of diabetic nephropathy progression. The ADA recommends annual screening for diabetic nephropathy in patients with type 1 diabetes after 5 years of diagnosis and in patients with type 2 diabetes starting at the time of diagnosis. Relevant guidelines and laws. ADA recommendations for nephropathy screening in diabetes. How do behavioral strategies such as motivational interviewing support patients in improving self-management of their diabetes, particularly in overcoming barriers to care? Answer. Motivational interviewing is a patient-centered communication technique that can be particularly effective in helping individuals with diabetes improve self-management by addressing ambivalence and enhancing motivation. MI focuses on exploring and resolving discrepancies between a patient's current behaviors and their long-term health goals. It empowers patients by encouraging them to express their reasons for change, which increases the likelihood of adopting healthier behaviors. For diabetes management, MI can help patients overcome barriers to care such as fear or denial about the seriousness of diabetes, lack of confidence in managing diabetes, or feeling overwhelmed by treatment regimens, socioeconomic barriers that prevent access to necessary medications or lifestyle resources. MI helps patients set realistic, individualized goals for managing their diabetes, such as improving diet, increasing physical activity, or adhering to prescribed medications. What are the primary causes of diabetic neuropathy, and what role does glycemic control play in the prevention and management of this condition? Answer. Diabetic neuropathy is primarily caused by long-term hypoglycemia, which leads to nerve damage due to chronic high blood sugar levels. The condition is characterized by symptoms such as pain, tingling, numbness, and weakness, most often affecting the extremities. Chronic hypoglycemia damages blood vessels that supply nerves, leading to reduced oxygen and nutrient supply to nerve tissues. Glycemic control is the cornerstone in preventing and managing diabetic neuropathy. Tight control of blood glucose has been shown to slow the progression of nerve damage and reduce symptoms. The Diabetes Control and Complications Trial (DCT) and the UKPDS study both demonstrated that intensive blood glucose management significantly reduces the risk of neuropathy in patients with diabetes. Relevant guidelines and laws. ADA recommendations on glycemic targets for preventing diabetic complications. The Diabetes Prevention Program (DPP) findings on blood glucose control and neuropathy. Mrs. Thompson is a 60-year-old woman with type 2 diabetes who has recently been diagnosed with depression. She expresses difficulty in managing her diabetes due to feelings of hopelessness and fatigue. What would be the most appropriate course of action for her healthcare team? Answer: the healthcare team should address both Mrs. Thompson's diabetes management and her mental health. The most appropriate course of action includes screening for depression. The team should assess the severity of her depression using standardized tools like the Patient Health Questionnaire 9, PHQ-9, referral to a mental health professional. Depression in individuals with diabetes can significantly impact self-care and glycemic control. A psychologist or psychiatrist should be involved in her care. Collaborative care approach. Her diabetes care plan should be integrated with her mental health treatment, ensuring that her depression is managed alongside her diabetes. Behavioral strategies. Motivational interviewing and cognitive behavioral therapy can help improve her engagement with diabetes self-management. Effective management of both her diabetes and depression will improve her quality of life and likely lead to better diabetes control. What is the primary mechanism by which diabetic ketoacidosis (DKA) develops in individuals with diabetes, and how can it be prevented? Answer: diabetic ketoacidosis (DKA) occurs when insulin levels are insufficient, leading to elevated blood glucose and the breakdown of fats for energy. This results in the production of ketones, which accumulate in the blood, leading to acidosis. DKA is most commonly seen in patients with type 1 diabetes, but can also occur in individuals with type 2 diabetes under certain conditions. Prevention of DKA involves tight glycemic control, ensuring insulin doses are adjusted appropriately, especially during illness or periods of stress. Monitoring blood glucose and ketones. Patients should regularly check blood glucose and urine or blood ketone levels, particularly during illness. Education on illness management. Patients should be educated on how to adjust insulin doses during sickness and when to seek medical help. Relevant guidelines and laws. ADA guidelines for DKA prevention and management. National Institute for Health and Care Excellence (NICE) guidelines on managing DKA. What are the key factors that influence the development of cardiovascular disease in people with diabetes, and how can this risk be mitigated? Answer: the development of cardiovascular disease (CVD) in individuals with diabetes is influenced by a combination of factors, including chronic hypoglycemia. High blood glucose levels promote the formation of advanced glycation end products (AGEs), which contribute to endothelial dysfunction and atherosclerosis. Dyslipidemia. Many individuals with diabetes have elevated levels of LDL cholesterol and triglycerides, which contribute to the buildup of plaque in arteries. Hypertension. High blood pressure is common in people with diabetes and accelerates the development of atherosclerotic changes, inflammation, and oxidative stress. These play a role in the development of atherosclerosis in diabetes. To mitigate the risk of CVD, strategies include controlling blood glucose, managing cholesterol and blood pressure, and promoting lifestyle changes such as diet and exercise. Statin therapy and CE inhibitors are commonly used in patients with diabetes to reduce cardiovascular risk. How does early detection of diabetic complications impact patient outcomes, and what are the most common screening practices used in diabetes care? Answer: early detection of diabetic complications allows for timely intervention, which can prevent or delay the progression of conditions like diabetic retinopathy, nephropathy, neuropathy, and cardiovascular disease. Regular screening is essential for identifying complications before they cause significant damage. Early detection allows healthcare providers to implement appropriate treatments such as optimizing glycemic control, controlling blood pressure, and using medications like ACE inhibitors or statins. Common screening practices include eye exams, annual dilated eye exams to detect diabetic retinopathy, urinary albumin screening, testing for microalbuminuria to detect early diabetic nephropathy, foot exams, regular inspections to detect diabetic neuropathy and prevent foot ulcers, blood pressure and lipid screening to detect and manage cardiovascular risk. Relevant guidelines and laws. AD8 Guidelines for Diabetes Screening and Early Detection of Complications, the UKPDS study on the benefits of early intervention for diabetic complications. What are the primary risk factors contributing to the increased prevalence of diabetes in older adults, and how should diabetes management strategies be tailored to address these factors? Answer: the prevalence of diabetes in older adults is rising due to a combination of age-related physiological changes, increased life expectancy, and a higher incidence of comorbid conditions such as hypertension and cardiovascular disease. Key risk factors include age-related physiological changes. As people age, insulin resistance increases and beta cell function declines, which can contribute to the development of type 2 diabetes. Polypharmacy: older adults are more likely to be prescribed multiple medications, some of which may interact with diabetes treatments, either enhancing or inhibiting their efficacy. Cognitive decline: older adults with diabetes may struggle to manage self-care tasks due to cognitive impairments. Physical inactivity and obesity: age-related reductions in physical activity and muscle mass can exacerbate insulin resistance. Management strategy: management in older adults requires a more individualized approach, taking into account life expectancy, comorbidities, and cognitive status. Glycemic targets should be adjusted to prevent hypoglycemia, and treatment regimens should minimize polypharmacy. How can cognitive decline affect the management of diabetes in older adults, and what strategies can a diabetes educator implement to help mitigate these challenges? And so, cognitive decline, which is common in older adults, can significantly impact diabetes management by impairing memory, decision-making, and the ability to perform routine self-care tasks such as blood glucose monitoring, medication management, and dietary choices. Cognitive impairments increase the risk of medication non-compliance, poor self-monitoring, and difficulty recognizing symptoms of hyper or hypoglycemia. Strategies for mitigation: simplified treatment regimens, tailor medication regimens to minimize complexity, once daily dosing to reduce cognitive load, use of technology, implement tools such as reminder alarms, smartphone apps, or glucose meters with built-in alarms to support adherence. Caregiver involvement: encourage the involvement of family members or caregivers in the management of diabetes, especially for patients with moderate to severe cognitive decline. Reinforced education: use clear, simple, and repetitive educational strategies to reinforce self-care routines. Teach caregivers to monitor and assist with diabetes management. Mr. Thompson is a 72-year-old man with type 2 diabetes. He is currently on a regimen of metformin and a sulfonylurea. Recently, his blood glucose levels have been fluctuating and he experienced a fall at home. How should his diabetes treatment plan be adjusted to reduce the risk of hypoglycemia and falls? Answer: Mr. Thompson's case highlights a potential issue with his current diabetes management regimen. The combination of metformin and the sulfonylurea, particularly in older adults, can increase the risk of hypoglycemia, especially if renal function declines, which is common in older adults. The fall he experienced could be a result of a hypoglycemic episode, which is more prevalent in patients on sulfonylureas due to their mechanism of action. Recommended adjustments: review renal function, check kidney function, as metformin and sulfonylureas may require dose adjustments in renal impairment. Switch to safer medications. Consider switching to medications with a lower risk of hypoglycemia, such as GLP-1 receptor agonists, SGLT2 inhibitors, or DPP-4 inhibitors, which also provide cardiovascular benefits. Tighten glycemic control. While older adults may benefit from slightly higher glycemic targets, to prevent hypoglycemia is essential to balance control with the risk of falls. A target of HbAC 8% may be more appropriate for Mr. Thompson. Education on hypoglycemia awareness. Provide education on recognizing and managing symptoms of hypoglycemia and recommend carrying glucose tablets. Why is polypharmacy a particular concern in older adults with diabetes, and what are the key considerations when managing drug interactions in this population? Answer: polypharmacy is a common issue in older adults because they often have multiple chronic conditions that require medications. For individuals with diabetes, polypharmacy can pose several challenges. Drug interactions: certain medications may interact with antidiabetic drugs, either increasing or decreasing their effectiveness. For example, beta blockers can mask hypoglycemia symptoms, and diuretics may increase the risk of dehydration and electrolyte imbalances in patients on insulin or sulfonylureas. Increased risk of adverse effects. Older adults are more susceptible to side effects due to changes in metabolism and organ function, particularly renal and hepatic functions. Compliance issues. Managing multiple medications can be overwhelming, leading to non-compliance or incorrect dosages. Key considerations for managing polypharmacy: comprehensive medication review. Regularly review the patient's medications to identify potential drug interactions and assess the appropriateness of each drug. Simplify regimens. Reduce the number of medications by choosing drugs that serve multiple purposes, e.g. GLP-1 agonists for both diabetes and cardiovascular benefits. Monitor renal function. Monitor renal function closely as it affects drug metabolism, especially for diabetic medications. Patient education. Educate patients and caregivers on the proper administration of medications and signs of adverse drug reactions. Which cultural considerations must be taken into account when developing a diabetes education program for a diverse patient population, and how can educators effectively tailor their approach? Answer: cultural competence is critical in diabetes education because cultural beliefs and practices can influence a patient's understanding of diabetes and their willingness to adopt lifestyle changes. Key cultural considerations include dietary preferences. Many patients may follow cultural diets that differ significantly from conventional Western eating patterns. Understanding these dietary restrictions or preferences helps in providing realistic and culturally acceptable meal planning options. Health beliefs. Different cultures have varied beliefs about the causes and treatment of diabetes. Some may rely more on traditional remedies or have misconceptions about insulin use. Language barriers. Communication can be a challenge if patients have limited English proficiency. Offering education in the patient's native language or using interpreters is essential for effective communication. Tailoring the education approach. Incorporate cultural norms. Engage with the patient's cultural norms by involving family members in education and suggesting culturally appropriate foods and exercise routines. Use culturally sensitive materials. Provide written and visual materials that reflect the patient's cultural background and use terminology they can relate to. Flexible learning methods. Use various teaching methods, including one-on-one discussions, group education, and multimedia resources to accommodate different learning styles. What are the critical components of an individualized education plan for a patient with diabetes, and how should goals be adjusted based on the patient's specific needs and abilities? Answer: an individualized education plan for a patient with diabetes should be patient-centered and tailored to the individual's specific needs, health literacy, and abilities. The critical components include assessment of the patient's knowledge and skills. This includes evaluating the patient's understanding of diabetes, their self-management skills, and any barriers they face, e.g. cognitive decline, financial limitations. Setting specific, measurable, achievable, relevant, and time-bound SMART goals. Goals should be individualized, such as achieving a specific HbAC target, improving self-monitoring of blood glucose, or adopting healthier eating habits. Identifying resources and support systems. Consider the patient's family, caregivers, and community resources to ensure consistent support. Ongoing monitoring and adjustment. Regular follow-ups should be scheduled to assess progress and adjust the plan based on the patient's evolving needs. Goal adjustment based on patient needs. Cognitive impairments. For patients with cognitive decline, simpler goals and strategies, e.g. using medication organizers, may be more appropriate. Elderly patients. For older patients, the focus might shift to minimizing risks, e.g. preventing hypoglycemia and improving quality of life rather than achieving tight glucose control. What role does adult learning theory play in diabetes education, and how can diabetes educators apply these principles to enhance patient outcomes? Answer: adult learning theory emphasizes that adults learn differently from children, particularly by drawing on their life experiences, motivations, and self-directedness. Principles of adult learning include self-directed learning. Adults prefer to take responsibility for their own learning. In diabetes education, this means engaging patients in the decision-making process about their treatment plans. Relevant learning. Adults need to understand how the information applies to their own lives. Educators should make sure that the education addresses the patient's personal health goals and challenges. Practical application. Adults learn best when they can apply what they have learned to real-world situations. Diabetes educators can provide opportunities for patients to practice self-management techniques in a supportive environment. Application in diabetes education. Engage patients in active decision-making by discussing treatment options and letting them express their preferences. Use real-life examples that are relevant to the patient's lifestyle and challenges. What strategies can be employed to prevent hypoglycemia in older adults with diabetes, and why is this particularly important in this population? Answer: hypoglycemia is a serious concern for older adults with diabetes due to age-related physiological changes such as decreased renal function, reduced counter-regulatory hormone response, and polypharmacy. Strategies to prevent hypoglycemia in older adults include tightening glycemic targets, avoid overly aggressive glucose control. A target HbAC of 7–8% is generally recommended for older adults to minimize the risk of hypoglycemia. Medication adjustments: consider switching to non-insulin therapies, DGLP-1 receptor agonists, or adjusting insulin dosages to prevent overtreatment. Monitoring blood glucose: regular self-monitoring of blood glucose, especially in those on insulin or sulfonylureas, can help prevent episodes of hypoglycemia. Patient and caregiver education: educate patients and their caregivers about the signs and symptoms of hypoglycemia and how to treat low blood sugar promptly. Mr. Jackson, a 78-year-old male with type 2 diabetes, has recently started experiencing frequent falls. His medication includes insulin and a thiazide diuretic. What is the most likely cause of these falls, and how should his treatment be adjusted? Answer: the most likely cause of Mr. Jackson's falls is hypoglycemia, a common side effect of insulin therapy. Insulin combined with a thiazide diuretic, which can cause electrolyte imbalances and dehydration, may increase the risk of falls due to dizziness and impair balance caused by hypoglycemia. Recommended adjustments: assess hypoglycemia risk, review his insulin regimen, potentially reducing the dose or changing to longer-acting insulin to avoid fluctuations in blood sugar. Switch diuretics: consider using a potassium-sparing diuretic to minimize the risk of electrolyte imbalances. Monitor blood glucose more frequently. Increase the frequency of blood glucose monitoring to detect and prevent hypoglycemic episodes. Education on hypoglycemia prevention: teach Mr. Jackson and his caregivers how to recognize hypoglycemia and take appropriate corrective actions. Why is fall prevention particularly important for older adults with diabetes, and what measures can diabetes educators take to minimize this risk? Answer: older adults with diabetes are at higher risk for falls due to several factors, including hypoglycemia, neuropathy, and reduced muscle strength. Falls can lead to serious complications, including fractures and hospitalizations, which can negatively impact diabetes management. Measures for fall prevention: hypoglycemia awareness. Educate patients on recognizing and managing hypoglycemia to reduce the risk of falls. Foot care: regular foot checks and proper footwear can prevent diabetic neuropathy-related falls. Exercise programs encourage balance and strength exercises such as Tai Chi or walking to improve physical stability. Home safety: advise patients on creating a fall-safe home environment, such as removing tripping hazards and installing grab bars in bathrooms.